An eminent speaker, eminent professor, أستاذة الدكتورة نهى بندق، أستاذ مساعد الاندوكرينولوجي كلية الطب جامعة اسكندرية، shortest teacher in type 1 diabetes. اتفضلي دكتورة نهى.
السلام عليكم، ازي حضراتكم؟ ان شاء الله باذن الله مزيد من طبعا توفيق و congratulations طبعا for the IADA team، بروفيسور مجدي حلمي، بروفيسور طلعت عبد العاطي، استاذ دكتور محمد عبد الرؤوف، وطبعا كل واستاذه دكتوره مباهج وكل organizing committee. Thank you Professor Suhair for my presentation، وطبعا سعيده بتواجدي مع my family endocrinology team بتاع Alexandria University. Actually, I'm going to cover a very interesting topic, short stage in type 1 diabetes. So, to start with, the link. The link between short stage and type 1 diabetes have been known a very long time ago. وindeed ان احنا بنلاقي ان diabetes mellitus is listed among the causes, the endocrine causes of short stage. Let me tell you in the coming few minutes what are the important questions that should be addressed in my coming presentation. So, are children with type 1 diabetes, are they truly short? Are they suffering from true growth hormone deficiency? This is what we are going to know. What about the growth patterns in patients with type 1 diabetes before the onset of type 1 diabetes and after the presentation? And does type 1 diabetes affect truly the final adult height, yes or no? I'm having a quick shaded highlight on Moriak syndrome, a severe form of physical retardation in patients having type 1 diabetes. Then I'm going to share with you a very interesting link between short stage in type 1 diabetes and microvascular complications causation. And then I'm going to end my presentation with special consideration diagnostic approach in patients having type 1 diabetes and true growth hormone deficiency, and tackling the safety and challenges and precautions in patients receiving growth hormone replacement therapy in type 1 diabetes. So before doing so, I need you to know some facts. The growth in children and adolescents is due to interplay of environmental, psychological, and hormonal factors, with growth hormone IGF-1 playing a very crucial role. So growth hormone is coming from the anterior pituitary, is going to act in its receptor in the liver, leading to production of insulin-like growth factor 1, the main mediator for the action of growth hormone. IGF-1 is going to bind to its protein, insulin-like growth factor binding protein 3, performing a complex, and together with growth hormone, both of which they are going to act on the growth plate, the end of the epiphyseal cartilage, leading to chondrocyte differentiation and acquisition of our linear growth. So mainly our linear growth will be dependent upon IGF-1 to a great extent, and to a lesser extent, direct effect of growth hormone. IGF-1, the main player in growth, is affected and influenced by multiple factors. Insulin is stimulatory for IGF-1 production, definitely growth hormone, as I've mentioned before, and good nutrition. And if the patient is having insulin deficiency, decreased growth hormone, or malnutrition, we would expect IGF-1 to be low, and hence you would expect that your child will be short. The second fact, we are having a lot of growth spurts along our life from infancy till puberty, with three main characteristic growth spurts. The first one coming in infancy in the first year of life, the second one in the preschool at 6 to 7 years of age, and the last and the most important one is the pubertal growth spurt occurring pre-pubertal, and it is parallel to sexual maturation, and it is responsible for a considerable final height in our adult height. So the first point that I'm going to cover, what about growth patterns before the onset of type 1 diabetes? Interesting news that they found that children at their onset of type 1 diabetes, they are taller than their non-diabetic peers of the same age and sex. And this has been clearly addressed in this mega study on 22,650 children with type 1 diabetes. This study was conducted in European countries, Germany and Austria, to investigate the effect of type 1 diabetes on growth and on the final adult height. Interestingly, they found that height at time of diagnosis of type 1 is above the average, especially in those having diabetes between the age of 6 to 11 years. Another interesting piece of information that weight gain in infancy and early childhood period is considered to be a risk factor for subsequent islet cell autoimmunity. That's to say, if you're having your child, your infant, having weight gain above the average in the first year of life, this child is subjected to increased risk of having type 1 diabetes afterwards. And this has been clearly shown in this study, showing that weight increase during the first year of life is positively associated with type 1 diabetes, supporting a hypothesis known as accelerated hypothesis or overload hypothesis. This hypothesis stated that insulin resistance is a common basis for both type 1 and type 2 diabetes. Insulin resistance accelerates beta cell hyperfunctioning, increase antigen expression and apoptosis, and exposing beta cell to destruction and autoantibodies through the glucotoxicity subjected to the islet cells. This is why we need a call to action. A call to action. We need to control the weight in infancy in the first year of life in order to avoid accelerated hypothesis and subsequent subjection of your child to the increased risk of type 1 diabetes afterwards. What about the growth pattern after the onset of type 1 diabetes? It was found that there is decrease in the linear height from disease onset to final idle height in patients having type 1 diabetes with diagnosis at childhood period and adolescence. And mainly due to affection of the growth spurt, I told you about the prepubertal and the pubertal growth spurts, they are affected to a great extent by type 1 diabetes, leading to decreased final adult height. And this has been clearly shown in this study where 1,685 children with type 1 diabetes diagnosed in the childhood period and adolescence, they have been followed up to the final adult height, and it has been found that the adult height was lower than the average, both in males and females. What about the pathophysiology, please? We are having more than one pathophysiological mechanism trying to serve why we are having stunted growth in patients having type 1 diabetes. The first accepted and the most important theory that insulin deficiency will lead to decrease in insulin-like growth factor 1 and insulin growth factor binding protein 3, with subsequent feedback stimulation of growth hormone leading to growth hormone hypersecretion. However, despite that growth hormone is hypersecreted, there is altered growth hormone receptor availability and downstream signaling leading to growth hormone resistance. So we're having decreased IGF-1 on one hand, growth hormone resistance on the other hand, both of which will lead to stunted growth in patients having type 1 diabetes. Moreover, patients having diabetes are having widespread inflammatory markers, namely interleukin C-reactive protein and fibrinogen, leading to direct suppressive effect on growth hormone and direct suppression of IGF-1. Besides, diabetes is known with diabetes micronutrient deficiency will lead to alteration in nutrient signaling at the growth plate. All of the above-mentioned mechanisms will serve together, leading to stunted growth in patients having type 1 diabetes. So what about the factors associated with poor growth in patients having type 1 diabetes? Poor glycemic control, it goes without saying, those having poor glycemic control are subjected to increased risk of stunted growth, those having longer duration of diabetes with positive correlation between the height at the diabetes diagnosis and the final adult height. The second point, the Muriac syndrome, it is a severe form of growth retardation in patients having type 1 diabetes, coupled with hepatomegaly due to glycogen accumulation hepatocytes with increased liver transaminases and dyslipidemia. Patients in this syndrome will be presented, this is a rare syndrome, by the way, because we are having now a very long list of novel insulin. This is why we don't see this syndrome nowadays. It is a constellation of short stature, growth retardation, delayed puberty, cushingoid appearance in the moon phase, protuberant abdomen due to associated hepatomegaly and proximal muscle wasting. I'd like to share with you a very interesting link between short stature in patients having type 1 diabetes and microvascular complication. This has been first discovered in the year 1995 when they studied 181 type 1 diabetic patients, and they found a clear association between short stature and eye, kidney, and joint complications in such patients. And then in the year 2009, this phenomena has been clearly addressed in two mega studies, the FINDIAN study and the DCCT trial. In the Finnish diabetic nephropathy study conducted in almost 4,000 patients, they found that shorter stature was associated with increased risk of both nephropathy and retinopathy, especially in patients having type 1 diabetes before the onset of 13 years. In this DCCT trial, they found that both the patients having short stature with type 1 diabetes are 2.4-fold increased risk for progression to diabetic nephropathy as compared to other patients with higher quartile heights. What about the proposed mechanism trying to explain them together? In the year 2009, when they tried to explain these phenomena together, they found that impaired growth velocity is just a marker in the childhood period for disease control. So if you're having a patient having short stature and microvascular complication, a common link between them and childhood exposure to diabetes. Another hypothesis is the common soil hypothesis, shared genetic factors leading to affection of both growth and nephron. This was in the year 2009. However, interestingly, in the year 2017, they found a very nice link between short stature and microvascular complication. Could you remember when I told you that in patients having type 1 diabetes, insulin is deficient with subsequent decreased IGF-1 and growth hormone hypersecretion? Growth hormone resistance occurs only in hepatocytes. However, in the kidneys, growth hormone receptor is upregulated, and IGF-1 is upregulated secondary to increased growth hormone. The increased IGF-1 and growth hormone receptor upregulation will lead to hyperfiltration, glomerulosclerosis, nephromegaly, and proteinuria, the main pathogenic factors driving the diabetic kidney disease. And by here, we found a very nice link between patients having type 1 diabetes with short stature and equestation for microvascular complication. So what about the consideration that we need to consider in clinical practice when I'm dealing with a patient having type 1 diabetes and true growth hormone deficiency? So as I have mentioned before, patients having type 1 diabetes are not true growth hormone deficient. They are having growth hormone hypersecretion. However, IGF-1 is the one which is deficient in such cases. However, the presence of both type 1 diabetes in children and true growth hormone deficiency is quite a rare disorder. But if I'm going to find this disorder, we need to have some special precautions and considerations. Mind you that insulin-like growth factor in patients having type 1 diabetes, even before clinical presentation, is lower than normal. So before clinical presentation of type 1 diabetes and at the onset, IGF-1 is lower than normal, and then it rapidly improves with insulin treatment, but later on it tends to decrease afterwards with declining endogenous insulin secretion. The longer the duration of diabetes, the lower the IGF-1 levels. So bear in mind when you are facing a patient having type 1 diabetes and true growth hormone deficiency in childhood period and pre-adolescence, mind you that you are not going to use the usual adopted figures for IGF-1 for the same years of the same age and sex. You need to have special consideration such patients. We need to have special tables, and now we are having designed IGF levels for patients having type 1 diabetes and growth hormone deficiency. What about treatment? A very important question raised in clinical practice. Are we going to offer growth hormone replacement therapy, yes or no? For the sake of time, let me give you the conclusion of the studies conducted in such issue. Growth hormone treatment is metabolically safe in diabetic patients. However, higher insulin demands are considered. Insulin doses are adjusted according to glycemic control, but when you are going to offer your patient growth hormone replacement therapy, it goes without saying that glycemic control is going to be affected. This is why you will need definitely higher insulin dose. And because we are having growth hormone resistance in such cases, you are going to need excessive growth hormone replacement doses as compared to peers of the same age in such condition. And thank you.
شكرا جزيلا أستاذ دكتورة مها على المحاضرة، هي very scientific و clarified، ويعني حقيقي ذكرت فيها كل etiology of short stature in type 1 diabetic patients. وما ننساش وحاجة يمكن تبقى overlooked فعلا psychological upset. ما ننساش دايما ان psychological upset للchildren دول، خاصة لو diabetic state عندهم في ال early childhood period بيبقى psychological upset، وليه ده direct impairment effect على growth hormone secretion، direct effect، مش عن طريق اي حاجه تانية ولا عن طريق الانسولين ديفيشنسي ولا حاجه، direct effect، ودي بنقابلها كتير جدا. شكرا جزيلا دكتوره مها.
شكرا يا فندم.
دكتورة مها فعلا thank you. You touched a very important point, which is the growth spurt, usually missed in most of the staff in teaching. This is a very important point. Thank you.
It's my honor and privilege to introduce to you Professor Yahya Siraji, Helmi Siraji. Dr. Helmi Siraji is a professor of medicine and endocrinology in